Hello, this is Integral Dose Podcast, and my name is Sarah.
Hi, my name is Vale.
Hi, I'm Atika.
Another day, another dose. This is the podcast that covers all things related to or integral to radiation therapy.
Right, speaking of radiation therapy, I guess it's quite a technical subject. So in today's episode, we're going to talk about what is radiation therapy. We figured it would be useful to share some key important technical jargons so that all of us have a better understanding of what is being discussed.
So, first of all, let's us define what radiation therapy even is. So, RT in short is a treatment technique or procedure that uses high energy rays such as X-rays to damage cancer cells and stop them from growing.
Yeah, that's right. So it's interesting to point out right here that most of radiation therapy that you might have heard of is considered this form of radiation therapy called external beam radiation therapy, or abbreviated as EBRT. So this is where the radiation is actually delivered from a machine that's outside the body. So these high energy X-rays are aimed and targeted at the tumor from outside the body. So it is a completely non-invasive procedure, and usually the patient won't have to undergo any sedation or anesthetic or any surgical procedures for this.
So another type of technique includes brachytherapy. So this is an internal radiotherapy, which is more invasive, surgically invasive, where a small radioactive source is inserted within or very close to the tumor. So specialized equipment like afterloaders and applicators are used during this technique.
Yes, exactly, that's right. However, brachytherapy is really a whole world on its own, and if we have the chance, we can dedicate a future episode to look into this more and explore brachytherapy in detail. So I'd like to highlight that, brachytherapy is a more invasive procedure, but it's only used for certain types of tumors where it is practical to assess the tumor via specific routes. So this does involve a bit of sedation where necessary. And in fact, for external beam radiation therapy, we sometimes have some level of sedation for, let's say, our children, our pediatric patients as well. So it's not completely sedative-free lah.
Yep, that's right. Do you guys know in the old days, external beam therapy was actually delivered using radioactive sources? We call it the teletherapy unit or cobalt-60 units because they use the radioactive cobalt-60 to emit gamma rays, which are live sources and lower in energy and are actually still in use in certain parts of the world.
Wow, interesting.
That's very cool.
Yeah.
So the live source, which can never be turned off, is actually inside the gantry head forever.
That's right. Yes, forever.
In fact, the current cutting-edge techniques actually involve proton therapy or heavy ion therapy, and these use cyclotrons or synchrotrons, which are large circular particle accelerators that accelerate protons or particles, charged ions, within a ring to reach the required speed and energy for treatment. These, however, have a really large footprint, and their construction, project, and processes take a really long time and are a huge investment on the country's health system and the institution, the hospital that's building it. So they're not super common, but they are becoming increasingly common in today's age because of their advancements, because of their technique and the benefits that they offer.
That's right, View. So here in Singapore, there are actually proton beam therapy centers, and one of them even have 4 gantries supplied by a single synchrotron.
Right, yes. So even though we do have a lot of specialized equipment and very interesting ways to produce radiation, the bulk of the machines that we still use today is called the linear accelerator. They are also known as LINACs. Most of the radiation therapists would have come across and used a LINAC before.
Yes,
Yep.
that's right.
All right, so now that we have a brief overview of the types of radiation therapy that we have, let's talk a little bit more about some jargons that you might have heard if you've ever undergone radiation therapy or if you're just someone who's learning about radiation therapy.
Let's start with the first one. Do you know that in RT, we call an individual RT sessions as fraction? So most treatments are spread out over several days or weeks. Treatment is fractionated over a period of time.
Right, for example, if you have 10 sessions of radiation therapy, that will be called 10 fractions. And if you've completed 2 sessions of radiation therapy, it will be 2 out of 10. So that's why it's called fractions. Am I right?
Yes, that's
Yeah.
right.
Isn't it interesting that in radiation we call it fractions, but for someone who knows about chemotherapy calls them a cycle.
Yes, exactly. So this is such a useful distinction because patients may just be able to discuss with their doctors very efficiently, tell them which fraction they just went through, which cycle they just went through, and the doctors, their healthcare professionals, will be able to understand them very quickly. So I want to talk a bit about why it is fractionated. Why is the treatment not done one shot? And why is it spread out, fractionated over a period of a few weeks? So radiation therapy has actually been around since the late 1800s. So over the centuries, over the decades, we have discovered that fractionated treatment regimens produce better results in terms of tumor control and normal tissue sparing. So the whole point of delivering radiation into a patient's body is to let the radiation go into the tumor and to kind of avoid the normal tissue, the healthy tissue that we don't want the radiation to be deposited into. So this is the whole concept of radiation therapy. So, fractionating the treatment across an extended period of time allows the normal tissues to repair themselves between sessions. It gives them more time to recover. And it also maximizes tumor damage while minimizing harm to surrounding healthy tissue.
Yeah, so that's it. There are certain types of treatment that are also delivered in a single session or fraction. But of course, this would require appropriate calculation by the doctors and our physicists to ensure that it is safe for treatment delivery.
That's right.
Much like medication has dosage, radiation also have dosage as well. And the amount of radiation dose that we give to a patient is usually measured in a unit called grays. And the unit Gray is actually named after Lewis Harold Gray. More technically, it's defined as the absorption of 1 joule of ionizing radiation energy per kilogram of matter. Sometimes there's also prefixes like centigrade or CGY. So this is something like when we talk about meters and centimeters.
Right. Okay, let's talk about processes. Now we already know what radiation therapy is all about. We talk about how processes is like for individual patient who's going through RT. So the first process is called CT simulation.
Yes, this process involves taking a CT scan or a computed tomography scan where it uses X-rays in a circular ring around the patient's body and computer technology to reconstruct the images into a 3-dimensional image that can be scrolled through. So doctors can see the scan and visualize internal organs, bones, blood vessels, or any other abnormalities.
So the point of a CT simulation is actually to obtain images in the treatment position. So what do you know about treatment position? So sometimes the position that we want during RTs is specific to a certain site, and this position will actually help the RTs to reproduce it every single day. So for example, if the position requires a patient to arms up or arms down, leg raised, or any other position that is required of the patient. So patient has to be physically present for the CT simulation session. Some may or may not need what we call a intravenous contrast injection, in short, IVCs. So some patients do go through IVC, some patients do not. But IVC eventually helps to visualize blood vessels and lymph nodes better and help doctors see clearer and decide where exactly to deliver the radiation to.
Yes, that's right. So, all this being said, it can be quite challenging to achieve the exact same position every single day. So, over the years, as radiation therapy as a field has developed, right, we have developed very creative ways of immobilizing patients, making sure that they are not just in a stable position, but they have to be comfortable as well. And all this considered, we still have to make sure that this position is actually reproducible and achievable every single day, every single fraction. So we use a plethora of tools in our disposal. So we have a lot of emphasis on custom-made support structures like masks, cushions, molds, body molds, extremity molds. Is really very fascinating. And the concept of this is all the same. It all boils down to keeping the patient's position exactly the same, very still, very accurate, very precise. Like we know exactly where the patient's position is, and we know that we are able to replicate this position every single fraction. Yeah.
Yep. So it has to be simple as well, because too many of difficult or complex immobilization devices might not be comfortable for the patients.
Yeah, exactly. That's right. So let's say in CT simulation, they achieve this very fantastic position, but if downstream, the treatment unit is unable to replicate and reproduce it, then it's kind of pointless, right?
It's also going to be difficult for the patient to reproduce as well.
Yeah, that's right.
So over here, one interesting tool to bring up is thermoplastic mask. This is where we use a certain kind of plastic that actually softens with the temperature, so we can insert it into a water bath or sometimes even an oven to heat it up. And doing this will make the mask more malleable, more flexible, so we can mold it to the patient's head, face, or other part of the body to keep their position still. And once the mask cools down, the thermoplastic property ensures that this thermoplastic will maintain its rigid, customized shape. So this thermoplastic mask or shell will be used for the same patient and only for that particular patient. So it's custom-made solutions for that particular patient. I think this is very interesting.
Yes, very, very.
All right, so let's now talk about some of the terms we use when we talk about a treatment plan that is designed for a patient. So a treatment plan is actually being designed by a team of radiation oncologists, dosimetrists, and physicists who will work together to generate a plan for each individual patient. So a computer software will calculate and produce a map showing the radiation doses given to the tumor and surrounding healthy tissues so that we can evaluate and modify to ensure that we meet the goal of maximizing dose to the tumor without overtly harming healthy organs. Speaking of organs, there is a term for this which is called organs at risk, and this refers to important healthy body parts near the tumor that we want to try protect from the radiation.
Mm-hmm.
Higher dose to an organ at risk would mean more side effects. So as much as possible in our planning design, we will try to minimize the doses to these organs at risk. And the next concept is called the target volume, or in general, the treatment area. This refers to specific regions where the radiation is aimed at, usually covering the tumor, and may include the regional lymph node chains that the doctors would like to target if it is affected, or to prevent tumor from spreading to those areas. And that's it for a treatment plan.
Yeah. So thank you, Atika, for the introduction on treatment planning. That's actually quite nice touch to today's episode. What I want to talk about next is probably the first day of the patient's RT session. So we will generally brief patient on the side effects, the skin markings and tattoos, and the setup processes. As with any medication or therapeutic procedure, sometimes there are inadvertent side effects. So some of the side effects are mainly the acute side effects or localized. They are generally recoverable after the radiation therapy sessions. So these side effects only affect where we are treating and not to the whole body. And the most common ones that we see are skin reactions. It will look something like a sunburn effect. Your skin will turn red. It'll be slightly a bit more tender. And fatigue is also another common side effects. But apart from these two acute side effects, there are also chronic side effects. Example, the taste bud sensitivity. It might not recover 100%. And then there could be also a secondary malignancy, which does not happen so often. And it could be way down the road. And also there are increased chances of bone fractures for the irradiated areas. And this one also, we don't see it very commonly lah. And every treatment area, we will expect a different side effects. So if you would like to know more about your side effects, then you should ask your radiation oncologist for more information on the first day of consult.
Exactly, that's very well said. I just want to bring up another point about skin markings or tattoos, because these are kind of like the defining feature for the patient when they're undergoing radiation therapy, is to have some form of skin markings. Mostly is in the form of a tattoo. So these tattoos are actually very important for letting the radiation therapist know and visualize where the tumor is, just by visually looking from outside the patient's body. So these tattoos are made during CT simulation before the treatment even starts, so that the radiation therapist can start using them on the first fraction. So the location of these markings depend on the region of the radiation treatment. For example, if you're receiving radiation to your colon or prostate in the pelvic region, then the tattoos will be around your pelvis area. Usually there's just one on each side and two in the front, one at the top, one at the bottom, so there could be a total of 4. It is, however, on a case-by-case basis. So for example, if the treatment region is really huge, then there might be up to like 7 or even more tattoos. But that being said, these tattoos are just very tiny dots. They look almost indistinguishable from a mole, almost like a mole. But as radiation therapists who have worked for a while, it comes with experience that we are able to tell them apart, and we are able to recognize the tattoos at a glance. Yeah, so we use these tattoos to help us visualize where the tumor is. Not all cases need tattoos, however. For example, if it is a brain treatment, the entire brain is well encapsulated within the thermoplastic shell, so there is no need for a tattoo there. We just have to get the patient underneath the shell, and there are markings on the thermoplastic mask. So in this case, the presence of a thermoplastic shell is sufficient. It's enough to make sure that the position is stable enough, and there is no need for additional tattoos on the skin. Yeah.
That's right.
Right. And the radiation therapist will actually assess every patient to ensure that we have enough information for us to position them on a daily basis. Right?
Yep.
Yeah,
Right.
exactly. That's what we do.
Alright. I don't know why I felt so not confident, but okay, never mind. Alright, so now that we have talked a little bit about the CT simulation processes, let's move on to the setup process during a patient's treatment or for daily radiation therapy. So for every session or fraction, the patient would first lie down on the treatment couch, and we would have to expose the areas where the tattoos were marked. This is so that the radiation therapist will be able to visualize these markings and tattoos, and we will use the lasers installed in the room to match to these markings that were made previously to get the patient into the exact same position as the CT simulation. Sometimes patients will actually hear the therapists call out numbers. It may sound random, but it actually refers to specific measurements that would help us with positioning the patient accurately.
Yeah, that's right.
So once the therapists have completed the first part of positioning, typically we will then go on to take x-rays or any additional imaging to confirm the internal position of the tumor and organs at risk, and after which we may perform small adjustments to the patient's position if it's necessary. Otherwise, once everything is good, we will proceed with treatment.
Yeah, that sounds great. That is a very good summary of what the patient basically has to go through. So yes, this is a very fast crash course about radiation therapy terminologies, and we've only barely scratched the surface today. We talked about a lot of things, but there is still a lot more to discover, and we will learn as we go along in our podcasting journey. Yeah.
All right.
Anyone has any last points to add on?
No.
Okay.
Alright, so please rate, review, and subscribe. Follow the podcast on Spotify or wherever you get your podcasts. Thank you for listening.
This has been your dose of content for all things related to integral to radiation therapy. See you in the next episode.
Bye-bye.
Bye.
Weren't we supposed to do that together?
It's okay lah.